I'm Tamara Johnson. I'm going to be going over a presentation that I did at work on neonatal hypoglycemia. I'm attending the University of Texas at Arlington, and I am currently in their Master's of Nursing Education program. So our learning environment, I was able to do this, like I said, at work. So Houston Methodist Baytown in Texas. My focus group was 3 new hires that are BSN trained. They recently took their boards, passed their test, and they are new nurses to our unit and new nurses to work. So they've never had any nursing experience. So we reviewed our content standards. So basically our policies, procedures for our NICU concerning hypoglycemia, and then also just went over the fact that, hey, they're nurses. They are required to act on their assessments, know how to assess babies, and then know about neonatal hypoglycemia. We reviewed the goals for the course, just basically explaining to them that they need to know what neonatal hypoglycemia is, know the risk factors, know when to check. I also gave them, before we went over our goals, a pre-assessment test just to see what they already knew about neonatal hypoglycemia, what they remembered from school, just to see where we were starting off from. So we reviewed our objectives, and so the objectives for this course were to have them apply their understanding of neonatal hypoglycemia, being able to articulate the education needed and the rationale for educating our parents on maintaining a good glucose level, importance of normothermia, so temperature control, and then feedings. And also the other objectives is to be able to explain and demonstrate the actions needed when you have a baby with risk factors. So whenever you have a baby that is small for gestational age, large for gestational age, born to a diabetic mother, born to a mother with no prenatal care, or if they're premature, so less than 37 and 6 weeks. And they'll also be able to demonstrate understanding of recognizing the signs of hypoglycemia. So we'll also go over typical symptoms of it. So we review the normal pathology of a baby maintaining their own glucose levels. So a baby is exposed in the mom. If the mom has no risk factors, her sugars, the mom's sugars, are typically between 70 and 115. Baby sugars run around the same level. So they're able to maintain a steady glucose whenever they're born. So what that looks like is at 2 hours of life, the baby's sugar should be higher than 40. And then once they've started feeds, kind of doing their own thing, at 6 hours it should be greater than 45, and it'll continue to normalize after that. That's what we're looking for. So in healthy term newborns without a mom having any risk factors, we know that a baby's glucose, as soon as the umbilical cord is cut, it drops 25 to 30 milligrams per deciliter. So you know a mom with a glucose of 70 at delivery, that baby's glucose may be dropping to 40. But if the baby has no risk factors, they typically have no issues increasing their own glucose without causing themselves to get sick. And in these babies, their glucose is not affected by the first feeding. So if they're breastfeeding and just not quite ready for it, they can go 6 to 8 hours without eating, or they're able to eat a normal formula and not have any issues. So we reviewed our abnormal pathology of neonatal hypoglycemia. So in a baby that's exposed to high levels of sugar, so if the mom is diabetic, then the islets of Langerhans in the pancreas hypertrophy, so they start overproducing. And so whenever a baby is born, remember the umbilical cord is cut, the baby immediately has to start regulating their own sugars, but their pancreas has still been overstimulated, so it still is producing more insulin, which causes the glucose to drop. So when the mother has high glucose levels, insulin levels are increased, and you see that with that hypertrophy. So whenever babies have that kind of a hit and their glucose levels need to be maintained higher than 45, which is the normal for babies, they oftentimes have issues with that. So say a mom with uncontrolled diabetes, those moms typically have large babies, so large for gestational age. Those babies have increased fat stores because of the high sugar levels that they've been exposed to, and it stimulates the growth of the baby through that extra sugar. So moms with an uncontrolled type 1 diabetes, those babies may be small for gestational age because of mom's metabolic issues that she's had. That baby's not able to grow correctly. So our babies that are at high risk for developing neonatal hypoglycemia are ones that are small for gestational age, large for gestational age, premature. The moms that have been diagnosed with some kind of diabetes, whether it's gestational or type 1 or type 2. And then those that have had no prenatal care, because you really don't know what mom's history is. So for a baby to be able to maintain their own sugar levels, they need to be able to eat. Well, if our baby is showing signs of low glucose, they may not be able to eat. Thermoregulation is super important in maintaining a glucose level. If a baby is exposed to cold stress, is trying to fight its own coldness, then that ends up burning fat, which leads to a decrease in a glucose level. So it ends up being kind of a cascade effect. If your baby's cold, they're going to start trying to increase their own levels, whether they're eating or not, and that can affect it. So our morbidity, mortality, if untreated, this can lead to severe illnesses and even neurologic injuries. So it's very important to maintain that glucose level. So we went over the importance of them educating the parents on how to keep your baby warm, the importance of feeds and the timing of feeds, and then the transition to life. So as soon as the umbilical cord is cut, the baby's doing everything on its own. Maintaining its own glucose is very important during this transitional period. We reviewed signs of hypoglycemia, so a baby that's tachypnic, a baby that's jittery or tremoring, a baby that cannot regulate its own temperature, so it's cold despite what you do, it cannot keep itself warm, a baby who's super lethargic, poor tone. Those could all be signs that the baby has a low glucose. And just a little extra bit, babies born to diabetic mothers have an increased chance of developing diabetes themselves. So that's education that needs to really happen prenatally. So we also reviewed treatment options. So as a nurse, you need to know when to check those glucose levels out and what you're looking for. So if your baby is asymptomatic, but you're following the protocol, you want to feed your baby if you've got low sugars, whether that be breastfeeding or supplementing with a regular formula. And then if your baby's sugars still aren't able to be higher than 40 or higher than the 45, definitely you'll talk to your doctor and they may order a higher calorie formula. If a baby's blood sugar is less than 25 initially, or despite whatever you have done feeding wise, then that's typically an automatic admission to the NICU, because they're going to need some IV intervention and get some D10 bolus going. So we reviewed our hypoglycemia protocol and management for our asymptomatic babies. So these are the babies that are at risk. So remember the SGA, the LGA, less than 37 weeks, and mom with no prenatal care. And those born to diabetic mothers, and then the symptomatic. So if you're symptomatic anytime while you're in the hospital, you may get your sugar checked, or that's kind of an easy thing to check to see if that's an issue we're dealing with. So in meeting all of our objectives, we went over a case scenario with when they would utilize this treatment options, and they were able to devise a plan and explain what steps they would take to check the sugar. They were able to give demonstration on what they would teach the parents, what they would tell the doctor, what they may suggest to the doctor. If it's the middle of the night, the doctor doesn't seem to be following the protocol or needs reminding of what the protocol is, because as a nurse, it's very important for you to know that we've got to help communicate with the doctors, and sometimes they need a little help reminding. So we reviewed everything in conclusion from what we were going for. We met all of our objectives. Our goals were reached. And then I provided the references that this was created from. I've got several nursing articles. We also used our book as well. Thank you.